oh my gosh, I listen to all these beautiful names, these brilliant scientists, and it's a great honor and a privilege to be between them. They're coming here. I wish I could be here for the next time. I would sit down. I was in UC Davis, and when I met him, oh my gosh, he has a beautiful program. You guys need to see his presentation. It's beautiful. Thank you very much. As I mentioned, it's a great privilege for me to be here. You have seen this beautiful center, what a beautiful center, and the course as well. This is very nice in the state-of-the-art program together. And also to see my friends. Rain is here. I know Rain a long time from the field, and she can thank you all. All right, let's see my pointer here. It's work, I think it's working right now. No pointer. This one? Just help us a bit. No. So many pointers, I can see. If you point to this, perfect. Let's see if I can come back. Point to that. I can use the board. Yep, perfect. That should be fine. Don't worry. Thank you. Perfect. No problem. Thank you, guys. So I have no conflict of interest. Unfortunately, I wish I had billions and billions to disclose, but nothing. Nothing. Lot of pharmaceutical industry here, but nothing. Anyway, but first and foremost, I would like to acknowledge the people that actually do that hard work. Specifically, Laena, the lady in the middle here, she works in my lab, and I'm glad to say that yesterday she received her CDA. I'm from FAHA. CDA is really great for career transition as well. She did 95% of this work, which I'm going to present today. And she's hard as well. Maybe I would say, maybe you can apply here, Utah as well. She's doing a beautiful work in the cardiac function, which I don't understand anything. Zero. She did the work. Ken McCarthy, he's my main collaborator. He's assistant professor. He's a junior faculty. My main collaborator, but also my husband. I can use a little bit this. Two kids. So you have two kids. Ken McCarthy has two kids. He's also plays soccer as well. He's to French college. So, and he's from New Zealand. So, and my main collaborator is not my husband, no conflict, actually, does the hard work. Thank you very much. And Wayne Vincent, he's a brilliant mind. He does all the bioinformatics thing, which I have zero expertise. And I learn a lot. I'm trying to learn a little bit with him. He's geneticist as well. Thank you. So I don't need to say to you guys on the nephrologists as well how important hypertension is to Americans, right? Now we know that 50% of adult Americans, they have hypertension. This is a terrible scenario. It's the same thing to say if I divide this room here in half and you guys here have hypertension. I'm sorry. Or going to develop hypertension. That's the reality. Imagine how terrible. And you know what the worst part? Because we can treat hypertension. We can treat, you can control hypertension, you can treat, but people don't treat. They are not aware of all that. And that's a terrible situation. And the result for that is high number of people with stroke, dementia, as you probably guys know that hypertension, terrible risk for dementia as well. All types of dementia, including Alzheimer, but also for kidney damage, for everything, for a lot of things. So we need to still focus in this disease from before the Civil War, right? We knew about this a long time ago, but we're still treating hypertension patients, right? Anyway, in terms of etiology, so this hypertension is divided in two categories, right? Primary hypertension or secondary hypertension. Primary hypertension affects 95% of the patients with hypertension. And the bad part is because we have no idea about the cause of hypertension. We don't know why that patient developed elevated elevated blood pressure? We don't know. So if we don't know the cause, we don't know how to cure as well. On the other hand, secondary hypertension is very severe. It's a severe condition, but we know the cause and we know how to cure. But can you cure? No. And the reason for that, for example, preeclampsia. We know pregnant women develop preeclampsia, and we know the cause. The cause is the presence of the baby. Can you cure? How? To remove the baby. Can we do that? No. Mothers are not going to do that. So we still need to face how to treat secondary hypertension. The same thing for renal conditions or chronic kidney disease. A huge risk for secondary hypertension as well. And it's super severe to develop stroke and dementia and other factors as well. And heart failure. Okay, guys, I know a lot of cardiac function. I need to mention about heart failure. Which hypertension is a terrible risk as well. And for women, for HFpEF situations as well, conditions. Anyway, but regardless of the etiology of hypertension and regardless of the identity of the patient or the sex or the race, anything, endothelial dysfunction is the core. It's always present in any type of hypertension, but also in all cardiovascular diseases. All of them. You guys can tell me any disease that can tell endothelial dysfunction is present. Dementia, aging, arteriosclerosis. I don't like a lot of arteriosclerosis. We always compete with arteriosclerosis folks, right? Because of different stature in the eye. But they have endothelial dysfunction. I try to convince them that they have endothelial dysfunction. We do have, but also obesity and other and aging. Several things, anything we have endothelial dysfunction. But we don't know why. Why endothelial dysfunction occurs in all these cardiovascular diseases. And we don't know if the causal consequence at this point. But we know the presence of endothelial dysfunction in most of the vascular bed. Endothelial dysfunction in the brain, which is very associated with dementia. Endothelial dysfunction in the heart, which is closely associated with cardiac dysfunction. In the kidney, in other tissues as well. All right. Anyway, we know right now our definition of endothelial dysfunction is very antique. Like we need to update. Actually, just update. We just published a guideline in endothelial dysfunction, which we actually update this definition in endothelial dysfunction. How is that? Endothelial dysfunction is an imbalance between vasodilator and vasoconstrictor factors. That's what you think about. Which is this means? Means that endothelial cells in pathology, in disease situations, release more vasoconstrictor factors and less vasodilatory factors, right? It's an imbalance. However, now we know that endothelial cell is very flat, very dynamic cell. It's not passive cell, just release factors. We know that endothelial cells can change their entire phenotype moment to moment in homeostasis condition, not in pathology. This change in homeostasis condition by different type of cells, depending of the situation, depending of the hypertension, flow, the signal, everything, and can restore and can return to the normal condition, right? And this is very dynamic. However, in chronic conditions, we now learn that this change in endothelial phenotype and endothelial function and endothelial dysfunction doesn't return to the norm. Right now, we don't know how to make it return to the normal endothelial function. Depends on the endothelial function, depends on the vascular tissue. Endothelium has a function, right? Or permeability, or blood-brain barrier protection, or for other cells. Depends. We don't know how to restore this. And one of the phenotypes that we learned is that endothelial cells, they get ugly, big, like these cells here. As you can see, they get really big, ugly, inflamed the cells, and very migratory, right? They look like muscle. They act like muscle. They actually are able to contract. If you guys don't know, for vascular physiology, folks, you guys know, but endothelial cells are not contractile cells. They don't contract, right? But when they get this feature, they are able to contract. Like a muscle, so different things. I don't know why they do that. To be a muscle, maybe as a compensator, or I don't know because of tension. We don't know, but you're still learning. And you know what's very curious? We also find endothelial cells. Most of the endothelial cells are present in the tunica media, the tunica intima in contact with the blood. These ugly big cells, like the ugly beautiful, right? But these ugly cells, they are present in the tunica media as well, which means they go there. And why they go to the tunica media? What they are going to do that? We don't know. We see the cells there, but then sometimes we confuse, we mix them with muscles. But actually, endothelial cells, if you follow them, then if you trace them, right? Anyway, so they look like this here. They get ugly, big. But the good thing, we can trick them and make them to become endothelial cells again. I don't know what point, but we still learn. Anyway, so then we start questioning, can we restore this? Can we make the cells again? Can we reprogram? Can we trick the cells and give a fresh start? Not by completely erase their phenotype, not by completely change their genetic, but by erase their epigenetic. Can we erase their hypertension signatures? Can you bring them back to the normal and give a fresh start? How can we do that? Right? That was always, I always want to answer this question. Can we restore this function? In this case, we don't know. And we're learning. In this project that we're going to discuss today is just to show you guys how we try to do that. Some moments were very positive data, none of them were negative, but I'm going to show the positive data, okay? Anyway, but how can you do that? And then when I start asking these questions, I learn about Dr. Yamanaka. You guys know very well him. Dr. Yamanaka, he paved the way for regenerative medicine. He changed. He won the Nobel Prize in 2012, and I think it was well-deserved prize. Because he changed the way we treat now medicine. And the majority of the labs, the one that work with cell molecular biology, they use his approach. What did he do, right? So Dr. Yamanaka is from Japan, and then he, at that time, before 2012, we didn't know that our cell, mature cells, adult, when you get adult, could be base cell again. We used to use stem cell, base cells in the lab. But from different circumstances, sometimes ethical conflict, like from fetus, right? Because the cells are they're very potent, right? They can make anything with that cell, make new organ, make new heart, make a new anything. Pancreas, imagine for them. But then he said, no, I think we can make our adult cells be base cells again. And how did he do it? He got our mature cells, in that case, of fibroblasts, and he treated the fibroblasts. He gave back increase, right, 4 master gene transcription factors that are able to erase and change completely the epigenetic and bring the cells to the base state, which called pluripotent. And then he showed for the first time these cells, iPSCs, which most of us use in the lab, right? These are well-known cells. These cells can do anything. However, as any study, it also has limitations. And one of the limitations of Dr. Yamanaka work is because one of the master genes, which we call the Yamanaka factor, one of these Yamanaka factors, in this case, CMYC, is close associated with cancer, right? Induced cancer. The reason for that is because cells from cancer, they proliferate a lot. And CMYC is one of the reasons as well. So how can we use this approach, beautiful approach that change the way for regenerative medicine, but by not induce cancer? No one wants to induce cancer in him, right? We want to avoid that. That's a big problem that we face cancer. We don't want to induce cancer by solving cardiovascular disease or other disease, right? And then in 2020, something like that, 22, I don't record, the guys from Sinclair Group, they said, okay, we can use Yamanaka factor, but let's exclude CMYC. If we exclude CMYC, so we don't develop cancer. So what they did, they use Yamanaka factors and they exclude CMYC, and they called OSK. Only by overexpress the other 3 master genes. which was OCT4, SOX2, and KOF, right? And what they did, they used old mice, and also that lost their vision, and they treated the eye with OSK, and they were able to restore vision in these animals. But also they were able to restore optic nerves in these animals, which was very difficult, right? It's really hard to restore nerves, right? We don't do that every day. And that was a good approach. However, again, as any other study has limitations, this one, they was not very specific. They developed this OSK, but could go anywhere, right? And then what we did, we then went to say, okay, can we bring this approach for Yamanaka factor? Can you do that in the cardiovascular field? Can you reprogram endothelial cells, but partial reprogram? I don't want to make baby cells. Again, I don't want that endothelial cell to be a baby cell again, because they're going to lose their identity. I don't want they lose their endothelial function. How can you only reprogram the cell by erase the genetic signatures of the disease, but without making them baby cells again? And then we use the OSCK, but it's very specific for vascular tissue, right? We did that for endothelial cell, for vascular smooth cell, but I'm going to show you the endothelial cells here. How we have limitations as well. We couldn't use ADP or other things. We use lentils because the size of our vector here, to have it very specific for endothelial cells. And also I like to see color, so I like to put EDF there in the middle, right? Because in the future I want to infuse to see where it can go, right? Anyway, so the first thing that we did, we standardized. Sorry, just need to see my time. You know, I keep talking too much. I need to control myself. And then we have to standardize that in vitro first. I need to learn how to do that first in endothelial cells. If endothelial cells will survive, I survive, we don't know. And different endothelial cells, brain endothelial cells, cardiac endothelial cells, several ones as well. And then we have three different groups that put saline, the lentils 8, that's L, and the lentils with the entire OSK12 express these genes. So the first thing what we did, we were able to see color, which I like green. Okay, we infect endothelial cells. After several attempts, endothelial cells don't like to be infected. They hate, I don't know why, something that I learned. So we need, I don't know what we did, but they got infected, and only about less than 50% of cells, some subpopulations of endothelial cells that get infected. I don't know whether because this was subpopulation or because the efficacy of the infect, I don't know. But we got some infected. The one that we got infected, the one that we want to study. The first thing that we saw, did these cells die? Nothing happened. I said, oh my gosh, or the treatment didn't work, or they're not dying. It's a good thing. So the first thing, based on the flow, did they die? No. So when we measure apoptosis, and also necrosis, the cells were viable. They survived. Good. And then we did this TM, but in detached cells. For this reason, they look weird here, but they're detached. They don't change too much the morphology. Very descriptive reasons right now, just to standardize the protocol. What we note, very descriptive data, but we saw in the cells, was this increase in CD31. CD31 is a signature for endothelial cell. It's a pickup, right? It's increasing endothelial cells. What does it mean? I don't know. It means anything, but we thought that this marker for endothelial cells increased. It's okay. Let's hold that result. And then we need to prove that we actually overexpress OSK in the cells. Of course, we went to the nuclei. We see increasing SOX, as you can see here, SOX2. But what's a good thing, we didn't see increasing in this histone here, which is a marker for DNA damage. Good, we are not damaging the DNA. We're increasing, we overexpressing this gene transcription factor, but we're not damaging the DNA. What are the cells become? I don't know. I know what we're doing that. I don't know. Second one, we also observed an increase in OCT4 in the nuclei as well. It's transcription factor for the nuclei. But no proliferation, no I was very scared that these cells will start to proliferate like cancer, right? And I said that would be a big limitation for us. But they don't proliferate a lot. They decrease migration a little bit. They stay quiescent. They stay their count, less than the normal endothelial cells. We don't know. They don't proliferate, which is a good sign, at least, if you don't want to develop cancer, right? And endothelial cells really hard to have tumorigenic pictures. And then KOF4, we didn't do IF because it didn't work. We tried several times. We couldn't see that KOF, IF thing. And then we did Wenceslau. And I want you guys to pay attention. We have 3 membranes. It's the same, okay? It's the same membrane, okay? So this is PBS, saline. This is the length of ours control. There is no expression of the genes. And this is the length of ours with the full all 3 genes. Pay attention to KOF with a dimer here, right? But at the same membrane, after you wash the membrane, as everyone does with what they wash, and we put this histone H3. This histone H3 is very important to protect the chromatin, to make the chromatin very tight, not open chromatin. Disappeared. The histone completely disappeared. This is the same membrane that was being blocked. When look at that, what did you do? I said, I'm not supposed to do anything to my postdoc. So I said, but how did histone disappear in the same membrane? Said, I don't know. I said, okay. And then I went to learn. We don't know. I said, how this happened? Because could you see double here? Why the top one disappeared, the bottom one not? Could you see? That's kind of crazy. And GAPJ is here. You can see some oscillations between. We still don't know why, but at least the stone is gone. And then I learned that when you have completely depletion of these stones, because you start to open the chromatin, so you can actually have access to reprogram. I didn't know. Look at my level of ignorance at that time. And I thought, okay, let's learn about it. And let's see what you can do with that. Because that's very specific. Let's do all the attack shipping thing that we can do just to understand, right? To follow the noise. And of course, we saw 100,000 of histones doing the same things, not only one. I just showing this data because they must be impressed. I saw it could see, I like to see change, right? I mean, old style, I like to see. If you tell me, this is statistical significance, I like to see the difference. Anyway, so that was beautiful thing. Okay, we are doing something, the cells are changed, but what they are become? The only thing we saw so far is increasing become, looks like increase more the signature for the cell, but what does it mean, right? Do we still have the function? Anyway, and the next step, we measure some markers for, I'm sorry, the color here, the CD30, this marker here. This marker is a progenitor cell marker, endothelial cell progenitor marker, which means the cells are starting to look like endothelial progenitor cells with very reparative. So they are turning to perhaps, we don't know what we call like, but progenitor cell like.
Sorry, this is Jax. Before we go too far, what are the origins of the cells? Are they embryonic or adult?
Adults.
Okay.
Very mature.
Okay.
Endothelial cell.
All right. Okay.
Yes, and that was that we didn't point this with endothelial progenitor cells.
Okay.
Because we work with endothelial progenitor cells, not hematopoietic.
Okay.
Tissue specific one.
Okay.
But we know they're very featured, no common information. They are not functional progenitor cells, but they start showing marks as progenitor cells.
Sure.
We are trying to see what they become. One point that we didn't notice, we didn't see marks for stem cells, so they are not becoming pluripotent things.
Okay.
We didn't see nanoid, for example, but you start seeing this progenitor thing like. Which is okay, very descriptive. Everything at this point is descriptive because we're standardized, learn what the cells will become. And okay, what can you do now with this treatment? Can you actually restore endothelial function? And then we induce endothelial to mesenchymal transition in normal endothelial cells. We can do that. We can make them spread and make them bigger the cells with these muscle muscle features. So we did that. And what they look like. So endothelial cells, when they look like muscle muscle in terms of the gene level, they lost their endothelial cells features such as PCAM, NOS3, which endothelial network cytosine, they lost there. And they gain a lot of features such as act with muscle. They start acting like a muscle, right? So we can do that. We change the cells in vitro, right? And then when we treat the cells with OSK, we don't see these, right? We don't see, they don't become, they still become quiescent and they look like endothelial cells, but they don't show too much muscle cell markers and they don't migrate anymore. They start very quiescent and they don't migrate a lot. Very steep experiment, very descriptive, right? But that is important to study, so you know what you're dealing with, right? Anyway, so okay, now that we got there in vitro, just few experiments so you guys can see what we're doing. Can we do that in vivo? Because the main result for me is blood pressure. Not blood pressure. I'm hypertensive. Let's see blood pressure. Change blood pressure. That's what you understand, right? And let's see that. Can we treat animals? Was another party for 2 years trying to several roads, didn't work, got stuck in the liver, need to change the leukovirus to make sure they are more efficient, right, for in vivo treatment. And then finally we got the right dose and the time. And then we used these animals called Schillinger mice. I like to work with hypertension. I love animal models of hypertension. All animal models you can see. But I like to use animals that are inbred or spontaneously develop the disease. And why is that? Why is that? Because when we induce the disease, for example, if I give angiotensin, right? I know the cause. I know angiotensin. I give angiotensin. I know it's a potent vasoconstrictor. It's halting water retention. It's very important for research. Don't get me wrong, okay? It's very important. Save a lot of lives. But I know the cause. And anything else is going to be consequence. Anything that's changed, anything is consequence of the elevation of blood pressure. Could be the cause there as well, could be, but it would be less easier to find the cause. So I like these animals that develop spontaneously. Anything, because we can start study them prior to the development, and you can target things that are changed prior to the development of hypertension and after, so you can compare, right? That's the thing for disease we use. And at that time when I moved to South Carolina, everyone just wanted SHR, but SHRs are rich, which is very nice. That's a great model. I love SHR. But to put this 100 million leukovirus inside a big rat killed me. I said, we need to have more money to handle that. How can we? And then we start with this colony, which takes more time because they don't like to have babies or try to force them. But no, we asked me to have babies anyway. But they called BPH, and BPH was called blood pressure high and blood pressure normal. Okay, so they developed high blood pressure and normal blood pressure. Here's the proof. They develop it. We have it in radiotelemetry or in anesthetized. We always measure blood just to confirm. They have elevated blood pressure. It's not so severe like animal models, like angiotensin, for example, or even SHR, stroke prone, but they have hypertension. And female, right? Female as well, they have blood pressure. We don't see a lot of the type of, we don't know why, but that's something that we need to evaluate. So, and they have vascular dysfunction, microvascular aortic dysfunction, they're really bad. This actually, I measure when they are prior to elevation of blood pressure. So it means that these animals have endothelial dysfunction. Just for you guys that are not vascular folks, what this means is that on your left, you guys look on your left side is the increased concentration for phenylephrine. Phenylephrine is an alpha-1 agonist which induces vasoconstrictor. As you can compare arteries from hypertensive animals here, they contract faster, more stronger, because they're stronger. At least in the beginning of hypertension, they are big and strong. In the end of the disease, the arteries actually contract less because they look like a pipe. Like they are so hard because they replace muscle by collagen, so they don't contract anything. They are hard, fat, like calcified. But at the beginning of hypertension, they're strongest to compensate tension. If you guys remember, plot here on the thing, but to compensate that, right? So we have wall thickness, decrease the lumen diameter, so we compensate tension, okay? This is for protection. Anyway, on the other side, on the more, here, we have like increased concentrations for acetylcholine. Acetylcholine is important, a lot of people is a neurotransmitter, right? They induce vasodilation. Yes, and why is that? Because all the vascular tissue, they have an important receptor, muscarinic receptor. When acetylcholine binds, in endothelial cells, do the release of an important molecule called nitric oxide. So nitric oxide goes to the muscle and open the vessels. So induce vasodilation. When the endothelium is damaged, acetylcholine doesn't respond very well. Okay, so this is right in the beginning of hypertension. When the vessels don't respond well. And this is bad. If the vessels don't respond, if you remember, blood pressure depends on what? Depends on the volume and areas, right? Volume are the kidney folks here, which believe does something to hypertension. But it's more chronic, long-term control for volume. But moment to moment, changing the area, any change in the lumen diameter by contraction or relax, you change area, which you change pressure. Okay, so this is very important. So no relaxation there, no change in the total areas, increasing pressure. Okay, all right. Okay, so what we thought too in these animals is that these white little cells here, which is a co-localization between CD31 and muscle muscle, are endothelial to mesenchymal transmission. As you can see, they are not only present in the lumen here, but also they're in this muscle cell, the tunica media. So you can see endothelial cells when they look like ugly, they are the tunica media as well. What they are doing there, we don't know. Okay, here is another slide to show that we can see the cells in the tunica media in different tissues. Okay, so now that we know this animal model, they are hypertensive, they have endothelial dysfunction, they have vascular dysfunction, because I was more interested in the contraction, because I wanted to remove that endothelial to mesenchymal position from the tunica media back to the lumen. I want to understand if our treatment could do that, right? For male and female. Oh yeah, the first thing what you do, we need to show that we are able to infect them. So we are able to show EGFP, the capillaries, most of the capillaries. We didn't see a lot of EGFP in the large arteries and this is very mechanical reason, right? It's really hard to infect hearts, there's no a lot, or large arteries, or mechanical because pressure and flow, really hard. Capillaries, the pressure and flow is too low, so the contact with the virus and the cells is good. So you get a lot of infection. So you got a lot of brain infection, right? Brain, capillaries, the kidney, huge infection in the kidney, of course in the liver as a because later virus infection, a lot of liver unfortunately, and also we have a lot of mesenteric got infected as well. Anyway, and then we did the first another descriptive date, all this transcriptome, a lot of transcriptome, but they're important to guide you, but don't answer a lot of questions. We collect the arteries from the animals that were treated, and we went to do all the math to see if we improve these endothelial cells. Indeed, the endothelial cells from the hypertensive animals, what you do here, they increase, they look like more endothelial cells right now. They have a lot of pican, they increase a lot of pican, and also decrease a lot of collagen. That was a good thing that you could see. So it's okay. So it seems that we infected these animals and seems that endothelial cells are just they respond. Okay, at least at the level of the gene. All right. So in a bunch of them, what about blood pressure? We didn't restore blood pressure here, but we are able to see that the treatment with OSK or levothyroxine decreases pressure a little bit, not super the low levels.
So I ask a quick question. At the beginning, you told us the transfection rate is pretty low. It's like only about 15-20%. How about
50?
So how about this set experiment you are showing us? Did you check the rate?
Yes, what we did, the animals that show EGFP shining, the ones that we could see, we did IVs. When you put in the animal in the machine, you see a little bit shine. It's the animals that we kill and collect the arteries. The one that didn't show EGFP fluorescence, we don't know if it's an effect or not, but we didn't collect their arteries to not swing money, something we're not sure if got infected. That's very unfortunate, was a limitation in vivo, just to see if you could see the color or not. And we kill the animal based on what we see the increase in fluorescence or not, at least in one organ. If you would see, for example, the brain, like not in the eye, but you could not see the brain, but in the liver, in fact, not liver, the kidney, in fact, you could see a lot of endothelial from the kidney that fact would kill the animal and then collect the arteries to send to transcriptome. Otherwise, we would do the same thing for telemetry.
So I didn't mean it as a negative though.
No, yeah.
With the fact that you don't need to achieve the full transfection rate to have successful outcome. That's great.
Yeah, and we could, was not only the only, we don't know if the way the IV or because it's some subpopulation of endothelial cells get infected. That's another thing, that it's not only tissue specific, but inside of the tissue, some subpopulation of endothelial cells, we don't know, we still learn. So far, this is in vivo, we could control less, we couldn't control a lot. We did it completely by skin on, show fluorescence EGFP, let's kill, or let's put telemetry to measure blood pressure. Otherwise, we wouldn't do that because a lot of it was money. The limitation was money. And they think, oh my gosh, and EGFP. Anyway, so, and that we were able to see decreased blood pressure. So it's very selective. The one that we saw shiny, we consider they get infected for control as well, because we also infuse EGFP in the control animals. But the control animals always get, I don't know why. Another thing that we know is the cell that gets infected, they have less EGFP, because GFP needs to be transduced as well as a protein. We don't know what's because the cells were quiescent, was reprogrammed, was not synthesized GFP a lot, true. That was not the control animals, infected cells, and in vitro as well. EGFP, we could see a lot of more cells infected. But the ones that has EGFP plus OSK infected less, and actually less fluorescent to GFP. Doesn't make sense? Another thing that I learned from. Don't know. And then, of course, we went to measure vascular contractility. As I mentioned, we saw a huge decrease in vascular contractility. Was a good thing. I want to see if we could remove that in the DMT from muscle, at least functionally, right? And a decrease in collagen here, the fibers distribution here. That's very important for vascular stiffness of the arch that we measure as well. Sorry, guys, I'm almost done here. And then, what about females? Depressed. I almost kill myself. When you treat the females, blood pressure didn't change. Couldn't believe it. I was killing myself as a woman. I say, why? Why females? Isn't that your thing? No, we tried several times. They get infected. We could see the shining. And I said, why? And started thinking about maybe because these animals are too old. And because when we develop the colony, we need standardized to kill us forever to standardize into the in vitro studies with OSK, and the animals are getting older and older. So we start using these animals when they're 11 months of age, which means it's after reproductions. We cannot say menopause to rodents because they don't develop, but they something equivalent reproduction. They stop reproducing after 7 months. And I said, okay, let's use younger females right now to see if they can respond well. Maybe the endothelial, they have endothelial like endothelial, they look like endothelial cell, they will infect them with more cadeline, I don't know. And then we start using younger females. And then, I'm sorry, vascular change also is the precedent change. And when you start using younger females, here, we start to get a little bit more positive, more responsive. And I said, no, 7 months is okay. Let's use even younger. Let's use like 3 months of age right now. And that's what I'm doing right now. Doing to see if these animals respond. They start to respond better. And you know, guys, what's doing a parallel here is a huge stretch, but just doing a parallel. Have you guys heard about the WHI, Women's Health Initiative from this study? So this was a big study that we evaluate hormone replacement in women, for women, right? And then before that, we used to think that hormone replacement was bad. We start killing a lot of, which is true. We start killing a lot of women develop cardiovascular disease. But how hormonal replacement is that into women? So women start getting scared to not take more hormone. But then they reevaluate the study, WHI, and they notice that if the hormone replacement starts after menopause, after when they don't respond, actually it's worse. But if the hormone therapy starts during the onset of menopause or during perimenopause, it's very beneficial, very good to the women and actually to the cardiovascular system because the cardiovascular system responds to the treatment. So for this, we said, how the endothelial cells could be? Then we don't know, but maybe because they're not getting affected, because they need Venceslau, I don't know. But something was the age that changes into that the male doesn't respond when they are younger. Like, and I hate such sex difference. Trust me, because I have no expertise. If I see something sex difference, I don't know. But we need, right? Because I don't know. I don't have capabilities, but we see that thing. And how can we face this to say, let's start using younger rodent animals, mice, so they will be more responsive. And you could see a little bit better, which was a good thing, but not all. Okay, what about human right now? That's the last part. I'm almost done. But for human, we couldn't use lentils, right? Who wants to put a lentils with HIV in our? No one, right? They would run away and I would never get migraine for nothing. And I think, okay, because they like that big translational word. Which, by the way, they don't need, right? The United States don't need have translation. It's not a weakness. Okay, guys. Fundamental question languages are important as well. Actually, much important than translation. No. Anyway, but and guys, how can we do that? Can you use lentils? No. So how can we use? I said, okay, how can you use something that the future maybe be a vaccine for chronic disease, maybe hypertension, we don't know. And then I started thinking, we can use a vaccine similar to COVID, that is an RNA that doesn't integrate with the DNA. We said, okay, we thought, think about it, we got this sendai virus. Sendai virus, very nice virus, very dynamic, that doesn't integrate with the DNA, right? Doesn't integrate. Which a great thing disappear after some few days of infection. I think after 3 days, you don't see anymore, but we see overexpression. And then you start using human tissue with sendai virus, but with the same sequence of OSK. Let's do that. And then we got hypertension. Of course, we do all the requirements, right? The transcriptome thing that we love. Well, we got that all hypertensive cells from human patients is incredible. The endothelial cells is bad. They look like big ugly with a lot of collagen. And when you give the treatment, we improve a little bit. Here, remove collagen, improve Venceslau, we improve signatures of endothelial cells, which is a good thing. We could reproduce what we have done in vitro from animal cells. Which is okay. Using sendai virus. Good. All right. But what about the function? Can we see that these endothelial cells still are able to synthesize nitric oxide or EDH or prostocyte, anything? Let's measure something to see their function. And we measure nitric oxide. So as you can see, female cells, which are better than males, always, guys, in any aspect, female cells from hypertensive patients, they don't respond very well. They don't have a lot of nitric oxide. But treatment with OSK can improve a little bit, which is the main thing that I want to see. Okay? And in parallel, at the same time, we saw a reduction of reactive oxygen species, which makes sense because ROS deactivate nitric oxide and vice versa. Okay? That was a good data. We didn't have a lot of males respond here, but the OSK treatment improved nitric oxide and decreased ROS generation. And of course, finally, the function of the enzyme, which we want to measure, enos, right? We want to measure the function. We saw an increase in phosphoinos, but also in total enos here, which for me also makes sense because I was dealing with transcription factors and change the genetic expression of the protein for enos as well, not only activity. So we saw a huge increase in enos expression, but also in the activity here in endothelial cells from male hypertensive patients, female and male hypertensive patients as well. And that's it, guys. That's our time where I'm going to stop talking too much. But the main thing is the data we should learn. This is just kind of piece of puzzle that we publish and we learn that we can change. Endothelial cells are very plastic, very dynamic. We can use signatures, which is a good thing. What they become, I don't know. When they become extra, the rest thing, but you know that they still synthesize methoxide, which I want to see is a main rebound from the cell, right? We do, and it increases a little bit blood pressure, and females really hard to work. But then if you work with younger females, they are more responsive. I don't know why. They have better in the cell, but they respond better. At least for this type of treatment. And the good thing, can we use Yamanaka pattern? Yes, we can use. You can use country. I don't know, my alien is still there for almost 2 years and they didn't die. But they also didn't develop cancer. At least I don't think they are 80. They didn't develop. That is my main thing right now, which I try to understand. This is maybe would be a good step for the future treatment for chronic disease, such as similar to vaccines. We could actually reprogram and could change very specific, in a tissue-specific way that you could make our baby cells again. I wish I could be a baby cell again. But the limitation, we cannot make it pluripotent cells for endothelial cells or a cardiac muscle. If not, we die. We need the function of a cardiomyocyte and a two cardiomyocytes. We need it, right? The only thing we only erase the damage, the signal, the aging thing, what we hate get older, right? Erase that thing for our lives. And also prevent disease. That's the main thing. And who knows in the future we can save some lives. That's our main goal, right? Anyway, guys, thank you very much. This is our main lab. Changed a lot. This was our picture. Ken, me, the lab, and our collaborators, mainly these three guys here, Ken. And the family support, which also changed a lot. But thank you very much, guys. Thank you for the great opportunity.